So, hello, we were discussing in the previous video about the refractive errors, which are hyperopia, myopia, and astigmatism. Hyperopia is the disease in which we are unable to see distant objects, and myopia is a condition in which we are unable to see near objects. So, and astigmatism is the abnormal curvature of cornea, and to correct it, we use cylindrical lenses. In astigmatism, the defect is there is different refractive power at different axes because of abnormal curvature. So different image is formed at different levels, and we correct it with cylindrical lenses. So the next one is lens disorder. The disorders which are wholly associated with the lens. This is presbyopia. It is age-related impaired accommodation, focusing on near objects primarily due to decreased lens elasticity. Patients often need reading glasses or magnifiers. So the cataract, it is painless, often bilateral opacification of lens, can result in glare and decreased vision, especially at night, and loss of red reflexes. Acquired risk factors. It is increased age, tobacco smoking, alcohol overuse, excessive sunlight, prolonged glucocorticoid use, diabetes mellitus, trauma or infection. Congenital risk factors. The number one risk factor is galactosemia, then galactokinase deficiency. Galactokinase is involved in the galactose metabolism, and when it is deficient, there would be increased galactose in the blood, condition known as galactosemia. Trisomies such as 13, 18, and 21, torch infection like rubella, Marfan syndrome, Alpert syndrome, myotonic, myotonic dystrophy, neurofibromatosis type 2. Its treatment includes surgical removal of lens and replacement with an artificial lens. Lens dislocation, it is also called ectopia lentis. It is displacement or malposition of lens, usually due to trauma, but may occur in association with systemic diseases like Marfan syndrome, homocystinuria. So, this is aqueous humor pathway. So, what is trabecular outflow? First of all, let us see where the aqueous humor is produced. It is produced by the non-pigmented epithelium on the ciliary body. So these are the ciliary body, and non-pigmented epithelium produces aqueous humor. It decreases by beta blockers such as timolol, alpha 2 agonists such as brimonidine, and carbonic anhydrase inhibitors like acetazolamide. And then aqueous humor is produced here, and from here it goes into the anterior chamber, and from anterior chamber we can have two outflow tracks: trabecular outflow track, which is 90%, and uvosacral outflow track, which is 10%. So trabecular outflow track, it includes drainage through the trabecular meshwork, canal of Schlemm, epicellary vasculature increase with M3 agonist, carbachol and pilocarpine. So, if we are having increased intraocular pressure due to aqueous humor, and we want to decrease this pressure, so you can give M3 agonist like carbachol and pilocarpine. The next outflow track is uveosacral outflow track. It includes 10%. It is drainage into uvea and sclera, increases with prostaglandin agonist. And for example, latanoprost and brema, brematoprost. So these are the two tracks which are involved in the outflow of aqueous humor. Iris have dilator muscles and sphincter muscles. Dilator muscles which dilate the iris like pupil, and sphincter muscles which constrict the pupil. And constriction is caused by M3 receptors, and dilation is caused by alpha 1 receptors. Lens, it is suspended from ciliary body by zonule fibers. Muscular fibers in the ciliary body affect lens shape and position. So here are some information. Let's go to the next. Glaucoma. It's a very important topic. It is optic neuropathy causing progressive vision loss. Peripheral, then central. Usually, but not always, accompanied by increased intraocular pressure. Etiology is most often primary, but can be secondary due to an identifiable cause like uveitis and glucocorticoids. Fundoscopy. In fundoscopy, we can see optic disc cupping, which is normal, but in glaucoma there is thinning of outer rim of optic disc. So, mean to say, in fundoscopy we can find optic disc cupping. It is an abnormality. Normal finding is, yes, normal finding is in picture A, you can see here, but in this there is cupping. You can see this is the upper rim of the cup and this is the bottom. So open angle glaucoma, it is anterior chamber angle is open. In this glaucoma, anterior chamber angle is open. That's why it is called open angle glaucoma. Most common type in US, associated with increased resistance to aqueous humor drainage through trabecular meshwork. So the angle is open, but there is resistance to outflow. Risk factor include increased age, race, increased incidence in black population, family history, diabetes mellitus, typically asymptomatic and discovered incidentally. It is angle glare glaucoma. Is the next is angle glare glaucoma. In this, the anterior chamber angle is narrowed or closed, associated with anatomic abnormalities, for example, anteriorly displaced lens resting against the central iris, and in this way the angle would be closed. Decrease aqueous flow through the pupillary block, or then there would be pressure buildup in the posterior chamber. We can see in this picture here that the aqueous humerus is produced in the posterior chamber by the ciliary bodies. This is the posterior chamber, and from here through the pupillary area, the aqueous humor will go into the anterior chamber. And in the anterior chamber, this is the trabecular meshwork which is involved in the outflow of this aqueous humor. So in type 1, which was open angle, the angle was open, but there was some changes to the trabecular meshwork which would be age related or some kind of any abnormality. But in posterior or you can say angle closure glaucoma, there is anterior dislocation of lens. When the lens is anteriorly dislocated, it would push pressure into the iris, and this iris will move towards this cornea and angle would be closed. And the second abnormality could be in the pupil. Let's suppose if the pupils are constricted, how this aqueous humor will move forward into the anterior chamber. So there would be back pressure, and it would result in glaucoma. Yes, anteriorly displaced lens resting against the central iris, decrease aqueous humor outflow through the pupil, pupillary block, pressure buildup in the posterior chamber, peripheral iris pushed against cornea, obstruction of drainage pathway by the iris, usually chronic and asymptomatic but may develop acutely. Acute angle closure glaucoma, complete pupillary block causing abrupt angle closure and rapid increase intraocular pressure. Presents with severe eye pain, conjunctival erythema. You can see this redness erythema, sudden vision loss, halos around the lights, headache, fixed and mild dilated pupil, nausea, vomiting. Hurts in a hurry with halos, a headache and half dilated pupil. So you can see hurts in a hurry. Hurry means acute. In acute cases, there would be severe pain in eye, and we can find halos around the lights, like you can see here, halos around the lights, and there would be headache, and people would be half dilated, as we can see it is complete pupillary block. True ophthalmic emergency that require immediate management to prevent blindness. So you can see here it can lead to immediate blindness. Mydriatic agents are contraindicated. So you can see here the mediatric agents are contraindicated. Let's go to the next. In this, we can see this is the open angle glaucoma. The angle is open, and angle clear glaucoma. The angle is closed by the upward pushing of iris, and the angle is closed. You can see here, and there is pupillary block. These are retinal disorders.